I start, I just wanted to wish all the women a happy International Women's Day. I think it's a really important opportunity to pay tribute to all the women in healthcare for your dedication in trying to make our health service a better place for all our patients. So thank you very much for that. Today, we have a masterclass with 3 different speakers, and it's very much geared around the updates within the digital work sphere. It will specifically cover interoperability and how it may influence or be influenced by the frontline NHS colleagues such as yourselves. So we will start with the first speaker will be Paul Wright from the Standards Implementation Engagement team. And he will be presenting on UK medicines and terminology futures. And at approximately 1:15, we have Steve Marks and Jasmine Riley from the Medicines Data for Secondary Users Interoperable Medicines team that will be presenting on Powered by ePMA Data. And finally, we will have Andy Pritchard, a Program Manager in NHS England Transformation, that will be presenting on Breaking the Virtuous Cycle. As always, there is a questions tab for you to put your questions. I will do my best to get around asking those questions to our presenters. Any questions that don't get answered will be collated on a spreadsheet, which will be uploaded on our NHS Futures page. I will put the link to that page shortly as well. So thanks to everyone who has joined us. Without further ado, please may I introduce our first speaker, Paul Wright from the Standards Implementation team, and he'll be talking to us about UK medicines terminology futures. Thank you, Paul.
Thank you, Sangeeta. Can you hear me okay?
Yes, I can. Thank you.
Great. Thank you. Thank you very much for having me on today's agenda, Sangeeta, and good afternoon, everyone. Hi, my name is Paul Wright. I'm a pharmacist by background, and I'm now working as a terminologist in my current role in NHS England. So just to give you some background, I work across the pharmacy terminology team in NHS England. This is a team that manages the terminology products of the Dictionary of Medicines and Devices, also known as the DM&D, and also the SNOMED CT UK drug extension. And I also work across the digital and interoperable medicines program as well. So the focus of my presentation today is to give you an overview, but also an update of the work that we've been doing to enhance our 2 terminologies, the DM&D and the SNOMED CT UK drug extension, but also as well to signpost you to some information and resources to support frontline colleagues with the changes that we're making. Next slide, please. And next slide, please. Thank you very much. So just to give you all a bit of background to the terminologies themselves. So the DM&D is a dictionary of descriptions and codes that represent medicines and devices in use across the NHS. And the DM&D is an interoperability standard. So when information about medicines, which is used in the care of NHS patients, is being transferred electronically from one system to another, those systems must be able to output and receive DM&D codes. DM&D makes sure that different clinical systems can effectively talk to each other using a common coded language for the transfer of medicines information. And traditionally, DM&D is used in the primary care sector. It underpins the electronic prescription service. Traditionally, the SNOMED CT UK drug extension is used in secondary care as it supports different use cases there. And one of the challenges that we face between our 2 terminologies is are some alignment challenges, and this is due to differences both in terms of the content that's contained within our 2 terminologies, but also when the timing of the release cycles for the updates of our terminology as well, and as a result that has an impact on interoperability. So due to these differences, the same medication may have different information published about it, depending on what's available to the user at that time they access it. And so the enhancements that I'm going to talk through, which we're working through at the moment, are all about making sure that our terminologies are brought more closely together, they're aligned more, and this will help support interoperability. So since October, a project team that I'm part of has been undertaking extensive engagements with stakeholders who use DM&D data, including pharmacy prescribing and dispensing suppliers in primary care, in an emergency, urgent and emergency care, pharmacy automation systems such as robotics and electronic cabinets, ePMA and pharmacy stock control systems used in secondary care, but also companies such as data analytics companies, medicines, data vendors. We've also provided guidance to NHS trusts and others as well, all with the aim of raising awareness of the changes that we're making, but also to work collaboratively with these stakeholders to ensure that when we are making the changes, we're doing so with minimal impact, both to the system suppliers, but also to end users of the systems as well. Next slide, please. So this slide outlines the changes that we're making to the content of both of our terminologies. This information is available on some web pages that we've published around the content of the changes that we're making, but also around the timescales of the changes and additional support for you. And I've linked to that in my last slide. So this information, along with the timescales of the changes, as I said, that are on my final slide, are what we're asking people to refer to look at for the latest information. And under each of the headings that we have here on the changes, we provide more detail as to exactly what the change is about and why we're doing it, but also for users of the data, what considerations they have. Is this new data that's available to them? For example, the DM&D historic codes, which I'll talk through, it is only newly been available now, and that will open up new use cases and opportunities to use that data. So of all these changes that I have listed, we have now gone live with three of them, starting in the top left with the addition of the DM&D historic codes. So this data went live in January and can now be accessed through either our TRUD service, which is the historical way of accessing DM&D data, or now through our terminology server, which is a more modern and FHIR compliant way of accessing DM&D data through APIs. In terms of historical codes and data, so in DM&D there are concepts which can have a code change, and a number of concepts in DM&D can have this feature. And for these, we hold a current code and a previous code. Historically, if a code was to change more than once, so on a second code change, we would have a current code, a previous code, but then there would also be a third code, which we call the previous code. And it's been these third codes or these previous codes that are lost from the DM&D data because we only store 2 at any one time. So with the release of the DM&D history data file, the full history of current, previous and other codes from the history are all now available for users to use. And this is particularly useful to support the work of the VTM and VMP ID changes that we're making, and I'll come on to those as well. And the full historical data is also available in our DM&D browser now. So that's a browser that you could use to look up DM&D concepts and products, etc. And in there, we now have the full history that you can see. So we've also gone live with updating the current DM&D VTM content. It's already gone live in DM&D, and it's expected to be reflected in our SNOMED CTUK drug extension, which will be published at the end of March. And lastly, we've also gone live with a batch of the VMP ID changes, which was a small sample batch of just 18, prior to going live with larger batches, which will start in May. And we've published all this data and all this information on the web pages so that it's completely transparent as to what's going to be changed and when. Next slide, please. Thank you. So this is my final slide. This slide just summarizes the resources which we have available to support colleagues with these changes. So the link in the first bullet takes you to the web pages which I've mentioned, and all the information is on there. We have also recorded a video for guidance for NHS trusts, which roughly lasts around 20 minutes. And we talk through in that video the changes which we think are most relevant to people who work in NHS trusts. We have already shared this through our product implementation and relationship management team, also known as PERM team. So hopefully people will have been able to see this already, but I just wanted to link to it again today. There is also a link to a technical guide for DM&D historical data for those that are interested, and this gives all the information such as the use cases of the data, but also how you can access the data as well. I'll put a link into the DM&D browser where you can go and look up DM&D data. And I've also put a link into the weekly release notes for DM&D, and this is where we communicate all our changes that go out with DM&D as it's released weekly. Lastly, we do have a central mailbox for any queries relating to any of the changes that we're making, and that will come into our project team to answer. So please, if you do have any questions, queries, concerns, then please do use that mailbox. So that is the end of my presentation. Thank you very much for listening, and Sangeeta, happy to answer any questions in any time I have remaining before the next session.
Thank you, Paul. That was really helpful and really well explained as well. I think sometimes it can be quite complex to explain what terminology is all about, but you've done that really well. So thank you very much for that. I suppose that we don't have any questions in the chat box, but is there an opportunity to maybe add some of the links that you've mentioned, because the slides are not hyperlinked, into the chat function?
Right. Yes.
And then what we can ensure the list. Sorry, go on.
Yeah, I can add them in. Would you like me to add them into the chat now?
Yeah, if you're happy to add them into the chat, and then what we could do is maybe facilitate a way to email it out as well for anyone who hasn't been able to attend the webinar live.
Sure, I'll do that now.
Brilliant. Thank you very much, Paul. Thank you for your time. So without further ado, we will move on to our second presentation by Steve and Jasmine. Both of them work in the Medicines Data for Secondary Users Interoperable Medicine Standards and Data Program. They are going to present powered by ePMA data. So thank you very much, Steve and Jasmine. Steve and Jasmine, I can't hear you yet, so you might be on mute.
Yeah, I think Steve was just talking, but I think he obviously wasn't heard. So
just do a sound check again.
He's just coming. He's just getting his headphones to see if that made a difference.
Hello.
Hello, Steve. Welcome.
Can you hear me?
Yes.
Thank you. Sorry, everybody. Yes, Steve Marks from NHS England. I'm a program manager within the Medicines Data for Secondary Uses workspace. What we thought would be useful to share today would be some of the use cases we've had in the ePMA data that we've seen, and so therefore we'll just cover some of those in both the COVID collection and our national collection. Can you go on to the next slide for me? So yeah, so we've got some insights that we've had with users of the data where we've collected this, held it centrally, and then allowed access to users to that data, and we'll just cover some of those key use cases. And something we're planning for the future, which is a national collection of ePMA data across all secondary care trusts that have an ePMA system. We're going to look at some use cases around that national collection. So if you just go on to the next slide, thank you. And the next one after that. Thank you. Just a bit of background. So we as a team within NHS England have been involved since late 2019, really commissioned from NHSX to really look at proof of concept about ePMA. Secondary care patient level information was a bit of a gap, so therefore we don't hold any of that. So it was seen as a gap when we were looking at a proof of concept. But come the pandemic, that was accelerated, and under some COVID directions, we landed a set of data from a single supplier, one of the supplier that has the biggest footprint, which was Careflow or WellSky, and we landed the data from those systems since December 20, and we've been landing it since then, and we continue to collect that data. And as you can see from here, we've collected around 80 million prescriptions so far, 407 million administrations, and data goes back to the beginning part of 2019. So we've got the comparison of pre and post pandemic. And also we'll continue that and continue to float that as long as the legal directions are in place till about autumn 24, which is when we think we stopped. We still have got those directions in place, which under the COVID directions does limit our use cases because it can only be COVID related. That's the purpose for collecting it. And that data is available through, we'll call it DARS, it's our Data Access Request Service within NHS England. And I'm going to hand over to Jasmine, if you could just go on to the next slide, to look into some of those insights from the COVID collection.
Hi there, I'm Jasmine. I'm a senior project manager at NHS England. You'll have to excuse me if I do say NHS Digital at any point, because obviously we've only just recently merged and we're all getting used to it. If you could move on to the next slide, please. So just to give you a little bit of background, obviously Steve's told you a little bit about the COVID ePMA collection. I'm pretty sure, judging from the type of people that I think are going to be on this call, that everybody understands what ePMA is, but just so that we're all on the same page, this is medicines data about medicines that's been prescribed and administered to patients in hospitals. It's patient level data that we're collecting. And we've been collecting this, as Steve said, almost on like an emergency limited scope basis for the last 2 years. So we thought that it was about time to figure out who's been using the data and for what purposes, because believe it or not, we don't have a routine way of finding that out, given that Steve and I sit in the part of the organisation, bearing in mind, obviously, it's a big organisation that develops and delivers this kind of data product. We are separate to the arm of the organisation, which Steve has mentioned, called DARS, the Data Access Request Service, which releases the data to customers who need to analyse it for research purposes or commissioning purposes or whatever. So we wanted to know a little bit more about it, partly because we should be taking more of a product-orientated approach to what we do. So in a nutshell, understanding whether the product that we're putting out there meets our customers' needs adequately and getting more feedback about how that product might change in the future. But also because if ePMA data is being used to positive effect in the real world and has had an impact, then we want to know about it. We want to be able to shout about it. It's useful for us to know internally, and obviously in terms of spreading that message more widely to the public in terms of collecting patient level data is important, and it's got a real sort of use at the end of it. Then anything that we find out about it is good. So that's why we did it. So this was an exercise that we started autumn last year, and it was a case of me digging into the application system to see who'd applied and got access to our data. So if I had more time on this call, I would take you through more detail about each applicant and what they did with the data, but as it is, I'm just going to give you quite a high level taste. So all of those applicants that you can see on this slide are those that had an active data sharing agreement with NHS Digital, as we were, NHS England as we are now. And the reason why NHS England is down there is because at the time we were separate organisations, so NHS England was considered a separate applicant at the time rather than internal user. So there were 7 DSAs, data sharing agreements. Health Data Research at the UK at the top there, that's a charity. It's a partnership comprising academia, NHS trusts, academic health and science networks. So it's the National Institute for Health Science Data. They do a lot of work with health data, and in this particular case they wanted to understand how sodium valproate was being prescribed in hospitals and other anti-epileptic drugs, and to follow the patient journey from secondary care to primary care and vice versa. Obviously, there are some safety concerns about the use of that particular drug in women of childbearing age because of the effects in the children born of those women who might take that drug. So that's why they were looking at that particular drug's prescribing. So they'd already looked at the medicines data in primary care and sent some of that information to the MHRA, and I believe they were planning to do so with their findings using the secondary care version of medicines data, but they were only part way through doing that study when we contacted them. So they were very, very keen to say that the life course of the patient is extremely valuable, understanding that, and that's what this data has led them to be able to do. Harvey Walsh, they're a private sector organisation, the health informatics supplier. They're part of the Open Health Group, and they develop and provide evidence for the likes of the NHS, pharmaceutical companies, charities, regulatory bodies like NICE. And they wanted to use the data to look at prostate cancer treatment and how that had changed over the COVID pandemic. They wanted to look at things like treatment type and how long it took for patients to get treatment, because anecdotally there was some evidence that medication was being given more orally in the community rather than inviting patients into hospitals, obviously trying to keep patients away during the pandemic. They were unable to start that analysis even though they'd got a data sharing agreement, because they needed to link ePMA data with cancer data, and that cancer data hadn't been uploaded, if you like, from Public Health England when Public Health England closed, so it needed to be transferred over to NHS England. It has now been transferred, so they're on the way with that research, but at the time of speaking to them it hadn't begun. University of Oxford, they're doing the recovery trial, which is a huge trial over, I think, about 185 sites across the country. So these are all patient trial sites where they recruit real patients to give them data about COVID treatments and which are the most effective. So looking at health outcomes tied to different COVID treatments. Now, they found out that a particular treatment was very effective, a particular steroid, and were able to write to hospitals about that, to the chief medical officer, and also sent their results to the World Health Organization, which has influenced the guidance on COVID treatment by WHO. But the ePMA data in that case was used as to validate what they were seeing coming out of their patient trial sites. So we can't lay claim to being able to influence COVID treatments just from the ePMA data, but they were basically looking to see whether what they could see from ePMA data was kind of mirroring what was coming out of their trial sites to see how reliable it was, because they wanted to say from a methodological point of view, yes, you can use this kind of data instead of setting up an actual patient trial site, for example. So that it wouldn't be possible to say that yet, but that was what their research was partly trying to do from a methods perspective. Queen Mary University of London, they didn't get hold of the data in time. They had an analysis resource available to them for a particular period, and by the time they got hold of the data, they unfortunately didn't have that analysis available to them to do that research. So, but what they were going to use it for was to look at the links between where there was suboptimal vitamin D levels in patients and their risks of getting respiratory tract infection, and B, a study which looked at risk factors for patients getting COVID who'd already had their booster vaccinations. So they were the two studies that they were interested in using ePMA for. NHS England, they had two applications in, but that's why they're listed separately. So the first application was non-commissioning related. It was more about the sort of effectiveness and safety of prescribing of antibiotics. So they were looking at antimicrobial resistance, and obviously this is a really big agenda nationally. There's a specific team, the National Prescribing Team in NHS England, who are looking after the National Action Plan on AMR. And so this research was to sort of feed actions towards the action plan. And they were looking at things like how antibiotics were administered, which type of antibiotics were administered, the course length of antibiotics, and how that had an impact on health outcomes. So although that piece of research was discrete and has been finished, it's possible that they'll carry on looking at it in more detail. But they were keen to tell us that part of what they were looking at was just how to use the data, because as well as it being our first time of collecting the data, it's data users first time of looking at the data and figuring out what shape and size it is and how they sort of use it for analysis purposes, so that was part of the job for them. The second NHS England application listed on there, it goes through a slightly different channel, DISGRO, which is the data services for commissioning regional officers. Pretty meaningless on its own, but basically it means that the data is being used to put into a national data repository that's particularly for commissioning use. So it could be for a variety of different commissioning uses at NHS England level, but at the time that we spoke to the applicant back in autumn, it hadn't been prioritised for use, so it hadn't been picked up and used yet. And then NICE, the last one on that list, the National Institute for Health and Care Excellence. They were interested in looking at the cost effectiveness of COVID drugs, the uptake of COVID treatments through the pandemic. They believed that commission was going to come through DHSC, but it didn't come to fruition in the end. So although they do have access to that data, they haven't done anything with it to date. Okay, if you could move on to the next slide, please. Is that the only, is that gone backwards? And the next one?
I think the other slides aren't there, Jasmine.
They're not on there, the other ones.
If you go, yeah, you've gone backwards there, I think, on the slide deck. I don't think they're there. So do you want to describe those advantages and that we've seen and the outputs from the information, Jasmine?
Yeah, just bear with me. I'm just going to pull up my own set of slides on my own computer so that I can talk you through it.
Apologies, everyone.
Yeah, sorry that I can't show you the slides, but it was a small sample that we spoke to, so it's hard to draw a huge amount of sort of solid conclusions because it's not a quantitative study, but from a qualitative perspective, there are certain points to draw out. The first thing is to say that, you know, there are huge reasons to celebrate here. This is the first time that we've seen this kind of data being made available. Primary care medicines data was first made available, and we followed that up with secondary care medicines data, and it's very powerful to be able to link those two in particular and link them to things like health outcomes data, hospital episodes, statistics, things like that. So everybody was extremely pleased that it's there, very supportive of there being a national level data set, because this is limited. This is only 26 trusts feeding into this at the moment, and it can only be used for COVID purposes, and obviously that will change in the future so that there can be a broader use of this kind of data. We've got advocates there in the system now, so we know who to go back to give us support for getting the national one off the ground and understanding more about users' needs and what they want to get out of this data and how they want to use it. We've got a feedback loop there to follow up on where we suspect there are some data quality challenges and things like that. The middle, sorry, you can't see the slides, I was going to refer to the middle box. Some thoughts from me personally are that this was quite hard to do from an internal perspective because we aren't very well linked at the moment with the arm of the organisation that deals with data applications and making that data available to customers. So that's something for us internally to grapple with and make that link back to that arm of the organisation so that they can be more aware of things like where there are pain points for applicants applying for that data. And you know, a lot of applicants have said that it's a very slow process getting to the stage of having an active data sharing agreement and then perhaps another wait to actually get the data extractions or get hold of it in a secure data environment after that. And reflections for us about things like being able to offer other data sets for linkage to ePMA is really important. So where the cancer data wasn't available for analysis in the cancer study that I just talked about, obviously that meant that there's now a delay in getting that research underway. Moving on to talk about some of the data quality feedback that we got. In general, as I've said, everybody will be extremely pleased to see a national version, but obviously we have to acknowledge at the moment that not every trust has ePMA. We expect that probably by the time we get a national collection off the ground, there'll be about 75%, something like that, with an ePMA system, but not every ePMA system covers all wards. So, for example, in that Oxford study where they were looking at data that came out of real patient sites, you know, they could see that there might be a patient who'd had some kind of treatment like ventilator treatment in critical care, but that wasn't mirrored by the data that was coming out of ePMA, because in that particular trust, ePMA didn't cover critical care. We know that some of our customers want things like home care medicines, specialist medicines, high cost medicines. That isn't within scope for this data collection for ePMA, but we know that it's a separate want that's sort of on our backlog that we're aware of. There was recognition that some of the free text that would have lent extra meaning to the data was denied. It wasn't there, which is partly to do with a data breach within the organisation, which meant that we had a review of which free text fields were made available to customers. So where there's a risk of patient data being typed into a free text box that shouldn't have patient data in, basically that meant that those free text fields have been denied. So yeah, that isn't particularly helpful. And some of what we found out was just that we needed to augment our guidance. So for example, DM&D coding, everybody understands what that is. Obviously Paul's just talked through a bit about that, but not all data customers understand the difference between that and SNOMED, or how they might link together, for example. And things like if a data customer wanted a cut of data at a particular point in time, their question would be, well, how do I know how complete that data is? Because different trusts submit their data at different points during the previous month. Some submit on a weekly basis, some on a daily basis, so that does reflect the degree to which that data might be complete. But I think some of those data quality feedbacks that we got just reflect to us that this is our first iteration, it's our first go. We didn't expect this to be without lumps and bumps, and yeah, just a reflection that we tried to, I guess, to take the burden away from trusts, in that we didn't want trusts to have to record or do anything differently on their side before we collected it. So we just collected it as it was stored in the system, and it's for us to sort of work out how much cleansing and processing and standardization we can apply to it, so that it makes more sense to data users once it's pumped out the other end of the sausage machine, if you like. We had some ideas that came up from some of our data users who we've followed up with on some of these data quality issues, for things like, you know, could we set up a user forum so that where there are questions around how you interpret that data, then they could be answered by fellow users. And just a reflection from us really on the benefits side, that benefits take a long time. So where you might have 14 applications in the system for the data, maybe only 7 have got to the stage where they've got an active agreement. Only 3 who've got an active agreement might have actually picked up and used and analysed the data. One of those might have resulted in a publication, and obviously a publication alone isn't enough to create a benefit. So for instance, if the research that was done on prostate cancer makes its way to Prostate Cancer UK, Prostate Cancer UK have then got to do something with that publication in order that it makes some effect in terms of safer or improved prescribing practices in hospitals. So it's something for us to consider really, in that our existing process of making data available and asking one question around benefits when we release that data, it isn't enough to really create an insight without doing an exercise like this. So it was definitely worth it from us to ask these questions, otherwise we just wouldn't have been able to get to this level of feedback. What else would I feedback? Let me just have a look at my slides. To play devil's advocate internally, we just asked ourselves the question, did it meet expectations in terms of the level of use? I think we weren't expecting it to be huge, in that we knew it was a limited collection, a limited number of trusts, and obviously a limited use basis, in that it was for COVID use only. So we think that once it's a national collection and it can be of broader use, then it'll have more applicants coming to it. And for now, you know, we've found out enough about it to be useful for us to go back and sort of iterate and improve. There was a feeling for us that we weren't aware that part of the process would be that data applicants wanted to use this as almost like a methodological exercise to get a feel for what they could do with the data. So that was, a genuine finding for us, that it doesn't necessarily result in a solid research output to begin with, and that we weren't aware that data applicants who put a genuine data application in might reach the point when they couldn't do anything with that data for one reason or another, like the commission that they thought they'd get to do something with the data in NICE's case didn't actually come to fruition. Some things for us to think about in terms of how we make this data available in the future. So in the past, we have made data available via things like data extracts, but in the future, it will be via a secure data environment. So we've got to think about what our customers need to be able to use that environment properly. So things like bringing their own data in. So if you think about the Oxford study that I mentioned and having patient trial sites, it would be of limited use being able to access ePMA unless they're able to link that with their trial site data. So we've got to take on board what some of those wants and needs are from our customers. And as I've said, we're going to feed some of this back internally so that we can improve our processes, hopefully, with things like how long it takes to access data. And I suppose just to finish on the fact that whilst it would be nice to have a nice shiny comms line, if you like, on ePMA has been used to achieve X, Y, and Z in the real world, we're not quite there yet. It hasn't been used to actually get to that point yet. But we've got our foot in the door. We know where data has been used by different researchers, etc. So there's an opportunity to follow up. So that's a positive from our perspective. Sorry, I've had to rush through that a little bit and that the slides weren't working.
Thanks, Jasmine. Do you just want to move on to the next slide? Yeah, this is just on the national collection. I'll go through these quite quickly. So there is a national collection. We are moving towards that. We do need a new legal basis, which we are just looking for. We suspect that will be published around springtime, and there'll be a compliance date of February 24, which is when we expect trusts to start then sending data. And it will be trusts that only have an ePMA system, and we're only looking for data from that main ePMA system. Can you just go on to the next slide? I have included here, just so, and you'll get these slides, some of the use cases for our national collection. So a lot of it focuses on some national strategies. So there's quite a few strategies it supports, and there are some big use cases, as Jasmine said, which is around AMR, overprescribing, looking at the use of new medicines and how effective they are. So there is lots of use cases in there which I won't cover, but you can read at a later date. If you want to go on to the next slide, which is the last slide, this is just more as a teaser potentially of something we could do in the future, which is we've done quite a lot of work on what we call legally restricted medicines. So it's identifying from the legislation how we consider medicines and which medicines are legally restricted. If it's useful to share, we can share that at a later date. I think it'd be quite useful within this group. And I'll probably just leave it there for questions.
Thank you very much, Steve and Jasmine. That was really insightful. I think in particular, it just makes us realize really how the data collected can really serve to be evidence in improving our practices in the future. We've got quite a number of questions in the chat or the question panel, but for time purposes, I'll pick one if I may. One of the questions from one of our listeners asked about whether the data collected extended to prescriptions by non-medical prescribers such as dietitians, and if the prescription count was inclusive of any amendments, or did it only include the original prescription?
So because it was the first time we've seen the data, it was anything that was in their ePMA system. So anything recorded in their ePMA system we collected. And it did look at changes within the system as well. So it was the updated record.
Brilliant.
If that answers the question.
Yeah, it does. And I think just another one, just very briefly, if I may. There's a lot of variation in how ePMA systems are optimized within trusts as well. So arguably the collection of data would be slightly different. do you have any concerns about what this may mean in terms of comparing data in the future and what that may mean for the future of our, optimizing our...
Agree, and I think we understand that there are differences even with the same supplier or different suppliers. ePMA systems are used in different ways, and therefore I think actually collecting it, being able to analyze it and look at it from the first time across the whole piece enables us to get that understanding. And I think one thing we could lead to in the future, which is then better standardization. But until we see the data, what you don't want to introduce is some standards which burden trusts or limit the way you use it. So it's actually understanding it to begin with, so that you can then make those positive changes to say, this is how we could standardize it and how we can improve it, so it becomes more standardized across all trusts and used in a similar way.
Brilliant. Thank you very much, Steve and Jasmine. The questions are in the questions panel if you're able to have a look at them. And without further ado, I will introduce our third speaker. Andy Pritchard, Program Manager, will be talking to us about breaking the virtuous cycle. Thanks, Andy.
Thanks, Sangeeta. Yeah, good afternoon, everyone. I'm Andy Pritchard, Program Manager. I work in the same team as Paul, Jasmine and Steve, but I look after a slightly different area, which is all around medicines interoperability. And the goal of this part of the programme is to ensure that medicines information can flow across the NHS in a secure and structured way, which means that we're looking at improving patient safety and reducing the amount of transcription as patients move between care settings. So in terms of how we're actually achieving that, is the team have worked and developed a set of standards which are based on international standards around how medicines are described. And we actually use as one of the bedrocks of our standards the DM&D that Paul was talking about earlier. In addition to that, we've generated, or a couple of years ago, we generated a standard for the dose syntax, which is the information that accompanies the item in terms of how that item is to be used or administered by the patient or by clinical colleagues that are dealing with the care of that patient. Those two standards are the bedrock, like I said, of a set of standards which are describing how medicines can be, for example, prescribed, or can be information about how medication is dispensed or indeed administered. So those are basically our products, if you like, and that's how we aim to get systems to start to define and use medicines in exactly the same way. So that's basically part of our role anyway, is to generate those standards, and those standards are published and are available, and we're working with system suppliers to start to introduce those standards into their systems so that you guys within the NHS can start to use them. So a bit of a long-winded introduction there, but it leads into breaking the virtuous circle. And actually, I'm not entirely sure if it's a virtuous circle or a vicious circle. However, the aim of what we're trying to achieve, if we just go to the next slide, please. The aim of what we're trying to achieve, and I've just covered that this is kind of an oblong version of our circle, is we're considering two very basic information flows, and I think it's wise just to consider what happens in the world today in terms of how medicines information is flowing. In the top section is really if a patient enters hospital and is admitted into that hospital, and then the other one is this the other side of the coin is when the patient has completed that hospital episode and is discharged back under the care of the GP system. The GP needs to have some information about what's happened. So in terms of medicine information, the GP practice system currently stores medicine information. As Paul mentioned earlier, we use the DM&D in EPS in terms of how prescriptions are transmitted to community pharmacy. However, the dose currently is stored as a free text. And indeed, some of that information is still transmitted to the community pharmacy in Latin. And just as an aside, I did a very, very non-scientific analysis of some dose information I was provided by a dispensing system. And I just looked at the number of ways of one to be taken daily was represented as a dose. And I got bored when I got to 150. So that just shows you the variance in the dosing instructions that are transmitted just from in terms of to one dispensing system. So so we take the example of the patient is admitted into hospital. The hospital system does have some mechanisms for finding out what medicine that the patient may be on. So they've got access to the summary care record, or in some and probably limited cases, a more structured way of looking through something called GP Connect, which is a service that makes GP systems GP systems information available to other care settings, or predominantly verbal information from the patient. And so what happens when that patient is admitted, the receiving clinician would transfer that information into the hospital system, and then it is used throughout the stay for that patient. We look at the bottom thread as the patient is discharged back under the care of the GP. A letter is then kind of sent to the GP, and there is an option here that there is a standard for a structured message if there is an electronic system here. And either a physical letter through the Royal Mail, or in the case of that structured message, through something called Mesh, which is an NHS messaging system. That information is used to feed the discharge information into the GP practice. And I've kind of laboured the point a little bit, but we have had horror stories here where the practice receives the information, or indeed receives it as a PDF rendered into their practice system. It's then printed, scanned, and attached to the record for that patient, and then there is the process of reconciling the information. So, for example, if the hospital episode has suggested a change to the patient's repeat medication, it's quite way down the process by the time the clinician is actually looking at that reconciliation as part of the process. So, hopefully you might see some of this from your side. Hopefully you might have, from the discharge side of things, actually have seen that the information gets sent out in this manner. So we're going to go to the next slide, and I'll try and explain what we hope is to the 2B position. So by the introduction of using the DM&D and the DO syntax and the new messaging standards that I spoke about earlier, once the systems are upgraded to transmit and store this information, if we take those same examples of a patient going into and being admitted into hospital, the hospital system can pull direct from, and it's called Direct Care API, it's the new name for the GP Connect service, to pull information electronically into the hospital system. The hospital system can consume this information, and it can understand that exactly from the use of the DM&D, the DO syntax, exactly what the patient's repeat or potentially some acute medication information is, and can consume that information and display it back to the hospital receiving clinician. So, for example, instead of the conversation with the patient at this point being, what meds are you on? It could, for example, be, when was the last time you took drug X, as an example, because they've got access to that accurate information. If we look at the other side of the coin on the discharge, again, the discharge information is sent as part of the overall discharge through something, in this case, the mesh system, back into the GP side. And again, we have that similar process that we saw on the hospital side, where the GP would receive this information and it would be consumed, and they will be able to validate and not necessarily rekey the medicines as part of that improved workflow. So the actual reconciliation process is a lot simpler, and it's a lot safer for both sides of this process. Okay, can we go on to the next slide, please? So I think you may have seen through in a previous session at the Masterclass, I think it was back in the last year, we had some research commissioned around the improvements that we could look to achieve in terms of the introduction of structured medicines and medicines interoperability around patient safety, and indeed the savings in terms of transaction time that potentially could be seen. And I think there's a general view that these numbers are conservative, but they have been validated. And there's some huge numbers here in terms of the potential time saving that we could achieve as a result of introducing this service. And I think more importantly to me is the box on the left hand side, which kind of talks about the patient safety side of things. So this to us is kind of the size of the prize. This is what we're aiming for. So the title of the presentation was all about kind of breaking this circle. And if we look at the two slides where I kind of explain the process flow, where we are currently is that, yes, we've introduced the standards, etc., but we do work with system suppliers, and we need those system suppliers on both sides to make the changes to kind of create and consume the information when it's in that structured form. And if we kind of, the reason I kind of called it the vicious circle is kind of there's no real demand for prescribing systems to make that change, because in the secondary care environment, you don't know that this is available, so you're not asking for it. And kind of conversely, there's no reason for a GP system to look at the consumption information, because you guys haven't got the systems to send that information through. And this is why it's kind of a vicious circle. And in terms of breaking breaking that circle, where what we do have, and I'm not sure if everybody can on the masterclass appreciates this, I'll just go through this in a little bit of detail. The NHS has the ability, or has a contract, a framework with GP system suppliers on the to basically introduce a capability based on priority in terms of what the NHS would like kind of primary care to do, etc. And it's quite a complicated framework, and we've been working with our colleagues in that area for quite a significant period to introduce the medicines interoperability capability onto that framework. And it's at this point that when that enters the framework, that the prescribing systems will actually be reimbursed for the development of introducing the dose syntax and the other areas around how to make interoperability work. So this is why I thought it was important to kind of come to the masterclass now, because we're very close to getting that put on the framework. It's actually quite imminent, and I feel, and I think the rest of the program feels, that this is actually kind of the turning point by which, once that is there and we know that prescribing system or GP systems are doing that development, it does break that circle, because that information will be available for you guys in the secondary care to receive that information in when a patient enters hospital. And as you create your discharge letters, you'll be able to send that information safely and securely back to the GP for them to do their reconciliation at their side in a much quicker and safer manner. So that's why, as I said, that's why this presentation was entitled that breaking that circle, because I think that's the one area where we can actually make that change, which is allowing the primary care system suppliers to be reimbursed for making that change, and we are breaking that so that structured information will be available. Okay, go on to the next slide, please. So this is kind of where, what we're asking for. So I've kind of gone through what the problem is in terms of medication information cart flow without the transcription currently, and we've got lots of benefits, and we have to start somewhere. That circle has to be broken. So it can't be. It was never going to be broken kind of organically. We had to do it by direct action, and this work we've done with the GP systems will break that circle. And I said we've got the ability to get the GP systems to do that, and this is something that the last point in the kind of summary section. I know it's kind of a bit basic, but I think it's worth kind of reiterating, is that when we talk about interoperability really benefits the receiving system, but it's the transmitting systems that need to do the work. So when we look at the discharge flow, we're asking, and you guys in the secondary care, to prepare a really nice structured medicines message from your system and then send it to the GP, who are going to have a much easier time, because they're the ones who are going to receive that nice structured message, and they can do their reconciliation processes a lot quicker and a lot safer. However, hopefully you can see by the fact that this is a circle, but by doing that, what that would start to mean is that these structured information starts to go through the system in its entirety. And it will mean that you will start to receive that information when it's your turn to receive the medicines information for patients as they are administered into the hospital. So in terms of, kind of being a bit cheeky here, just kind of saying that they ask, I think it's just worth, considering this circle when you look at any work that you're doing in terms of introducing or optimizing ePMA, and any types of medicines information transfer that you may have. The standards and the standards that I mentioned previously will support things like inter-hospital or inter-trust, or indeed intra-hospital as well, movements as well. It will support inpatient prescribing. When we upgrade EPS, it will be used within the EPS service. So, considering the use of these standards, I think, is important when we look at both ePMA and other medicines information transfer processes. Again, kind of work with your systems, your IT system partners, to understand how they're tackling the problem. There's, we kind of provide the standards, the definition of how meds is to be defined, but how they are used and used safely within the systems is the role of the system supplier. That's what they bring to this part of the party. And if you can see any of the challenges that we have in implementing this, there's an email address there that, please send any information, any questions, or even if you see some challenges or barriers that we haven't thought about. It would be really useful to get some frontline feedback as well. So that was the end of my slide. And I think we're just butting up to the 5-2, Sangeeta. So happy to take any questions.
Thank you, Andy. There's quite a few questions actually. One of the questions I wanted to ask you was, do we currently have any use cases or frameworks where we can kind of understand where we're at in terms of transmitting structured dosing?
We have one kind of live implementation as an inpatient prescribing and administering system, but I'll be honest, that didn't meet 100% of the standards. I think where we are is that we haven't any live examples which we can look back in terms of getting lessons learned or anything like that, because we're really waiting for this, the start of this circle to be broken by the GPs implementing it. So we haven't got any live implementations of the structured medicines to date. The whole reason kind of presented today was to say that this is imminent. But we haven't got any to date.
Brilliant, thank you. There was a question as well about how can we highlight to suppliers that they would be reimbursed for development so that we can encourage development?
I think that's they say we only have contractual relations with suppliers on the GP side, so that's where we can make that influence as NHS England. I know that that's a very sweeping statement, and there probably are local initiatives where there is central funding for this kind of work to be done. But I think my main kind of advice would be just to talk to your system supplier and use the commercial relationships that individual trusts have got with their suppliers, just to start asking the question about, this is interesting, we want to put this in, what are your plans, when are you going to introduce, that kind of thing. So I think it's more around the local arrangements, unfortunately. But again, if there's anything that we could do nationally, we will be willing to assist.
Brilliant, thank you. And the last one is just a very quick, short question, Andy. So will you envision that this will support the 111 service as well, the structured dosing?
It depends which part of the 111 service. Would 111 be able to receive information from a GP system and any other system? Because don't forget, there's lots of information stores of medicines that are out there. Absolutely, if that information is stored in the correct structure and the 111 system has the ability to consume with the relevant access rights, absolutely it would support that. If it's 111 in terms of prescribing, with the improvements in the EPS service, absolutely, again, it would support that as well. So I think the answer is yes, it will support that. It's just down to systems and access rights.
Brilliant. Thank you very much, Andy, for your time today. What I'll do is I'll summarize our masterclass as well. So just some final thoughts. Thank you to all our speakers today. We had an update on the UK Meds terminology. We understood aspects of why the ePMA data collection is so important to optimize our care with data analysis. And lastly, we had an update from Andy about the art of the possible should structured dosage be available to help improve the efficiency within the NHS as well. So I hope you've enjoyed the masterclass. Just a quick reminder as well, our next masterclass is on the 19th of April. So we look forward to seeing you there. And I thank you very much for coming for this masterclass and wish you all a good day. Thank you.